too.
All right.
Hello, everyone. I'm Jax. I'm a physical therapist at Cottage Hospital. We're going to go ahead and get started. If you could do me a favor and just mute it on your end. Perfect. Okay, sorry about the late start. We were working out a few glitches. Okay. Real fun fact before we get started. I was actually a student at CRH a few years ago, and Laura Isham was my amazing CI, and I had such an awesome experience over there. So this is a real treat for me to be able to present again to all of you. Logistic things real fast. This presentation is about 25 minutes, and then I'll leave time at the end for questions as well. I am recording this, so if any of your colleagues weren't able to attend, but they would like to see the presentation, I'll make that resource available to them. And then I'm also going to make the PowerPoint slides available to you as well, because there's a few resources in the addendum, specifically some of the articles that I looked at that might be helpful as well. So we will go ahead and get started. This in-service is in cardiac rehabilitation. Some objectives that I want to go over are to define phase 1 of cardiac rehab, establish precautions and contraindications to treatment, explain new sternal precautions, go over cardiac rehab outcome measures, go over the walking program progression, as well as the post-op sternotomy therapeutic exercises.
Can you let people in?
Yes, sorry. I'm going to let a few more people in. Okay. So just to get our heads in the right headspace, I want to start out with some cardiac anatomy. So here we have the human heart. You've got the right and left atrium, the right and left ventricles, and then you have the tricuspid valve between the right atrium and the right ventricle, and the mitral valve between the left atrium and the left ventricle. The deoxygenated blood is going to go out through the pulmonary valve into the lungs to get oxygenated, and then the oxygenated blood is going out through the aortic valve through the rest of the body. Okay, so there are multiple indications for cardiac rehabilitation: transcatheter aortic valve replacement, myocardial infarction, pacemaker, stent, angioplasty, heart valve repair or replacement. But the one that I want to focus on for this in-service is the coronary artery bypass graft, specifically because I think that's the patient demographic that you're seeing the most of in your setting. So the indications for a CABG are when the coronary artery atherosclerotic lesion progresses to the extent where the artery becomes severely or completely occluded. And you can see that in the picture in the bottom right-hand corner where there's near complete blockage because of severe coronary artery disease. And in this case, the heart itself is not able to become oxygenated with blood. For a CABG surgery, they start with a sternotomy, and then they're going to use an artery or vein graft. They'll usually use an internal mammary artery, radial artery, or saphenous vein, depending on how many grafts they're going to be doing. And then they use that graft to connect the aorta to the coronary artery that's affected by bypassing the coronary blockage site. So it's a very simplified version of a very complex surgery. And then let's talk about cardiac rehab. So there are 3 phases of cardiac rehab. Phase 1 is the acute phase, and it begins once the patient is medically stable following an MI or a CABG or a TAVR, any of those listed there. And this is done in the inpatient setting. And then once the patient progresses from that, they'll move to an outpatient setting and phase 2, which is what we have here in the hospital with our cardiac rehab outpatient clinic. And this is a subacute phase. It begins 1 to 2 weeks after discharge for minimally invasive procedures such as a TAVR, and 3 to 4 weeks after a sternotomy such as a CABG or valve repair. And during this phase, the patient progresses through exercises while being monitored on an EKG by a physical therapist or a nurse. So they're checking their rhythm throughout exercise, and they're also checking to make sure that they're hemodynamically stable by assessing their vitals before, during, and after exercise. Sorry, I'm going to admit a few more people in real fast. Okay. The patient will be in phase 2 for about 12 weeks for a total of 36 visits, and then they'll move to phase 3. And in phase 3, this is the more intensive training, still outpatient setting. And it begins at the end of phase 2 and it can extend indefinitely. So patients have a little bit more independence in this phase. They're not monitored on an EKG. We still assess their vitals before, during, and after exercise, and we still progress them as indicated, but they can also work in group exercise groups as well.
Visits is 11 visits.
Mm-hmm. I have a guy that's having.
He's not in cardiac rehab. Interesting. Why do you think
Maybe he should be.
maybe he should be? Yeah.
Sorry, technical difficulties.
So we would be considered acute when they're an
It is
inpatient.
going through on my end.
Oh, it is?
So we're phase 1. I mean, we're acute. I mean, when they're an inpatient.
Our phase 2, we don't have a KG on it.
Right.
We're not.
Hey
Yeah.
team, sorry, we're having some more technical difficulties. I
Well,
gotta
I
stop
think
share real quick.
but some of the questions that are going to come up are precautions in acute, which is here in inpatient.
They don't have a KG here, right? I mean, in patient.
No, I don't know.
Hi.
Share screen.
Oh, are you hearing our whole
Mind
conversation?
if I do this?
That's fine.
And then- So you were clicked on here, not on here.
Okay,
Cool.
cool. Now we share again.
Yeah, you're good. You're sharing.
Okay, and now I should be able to go through.
Yes.
Perfect.
Yep.
Okay, we're back on. So sorry, you guys. Okay, so the goals for phase 1, the acute phase of cardiac rehab, are safe mobility, safe discharge, promoting early return to ADLs, reducing the patient's risk of developing conditions secondary to bed rest, maintaining muscle tone, reducing orthostatic hypotension, providing medical surveillance, and providing patient and family education. Now, I know education is important with all the patients that we work with. Specifically with our cardiac rehab patients, we want to focus on educating them on adverse symptoms, teaching them activity guidelines, sternal precautions, going over family training, and also teaching them a home walking program and home exercise program. And again, with all of our patients, it's a multidisciplinary team approach. However, specifically, we're going to be working closely with the cardiologists, cardiothoracic surgeons, as well as our cardiac nurse practitioner as well. There are multiple benefits of cardiac rehabilitation. I just wanted to highlight a few here. Cardiac rehab has been shown to improve heart rate response, arterial blood pressure response in patients with hypertension, myocardial oxygen perfusion, and maximum cardiac output. But the big one is that cardiac rehab has been shown to decrease the chance of adverse future events by 50%, which is huge. Okay, I want to go over a few precautions and contraindications to cardiac rehab. So for these precautions, I just want to note that with any precautions, we want to take into account the full picture of the patient. So taking into account any symptoms that they're having, baseline medical issues that are going on. So this is kind of a yellow flag that makes you want to look out for if anything else is going on, but it's not an end all. For these precautions, you want to assess their resting heart rate. If it's more than 120 beats per minute, that's something that you should be a little weary of. And this is only if it's in sinus rhythm. So if a patient is in AFib, sometimes they're hanging out in this 120 beats per minute, and that's okay. But if they're 120 beats per minute at rest and sinus tachy, then you kind of want to take caution. Also, if they have a resting blood pressure greater than 160 systolic or greater than 90 diastolic, if they have orthostatic hypotension, you also want to note if they have symptoms with that as well. Sternal precautions, we'll go over that a little bit later. If they have uncontrolled AFib. And then you also don't want to be doing a manual muscle test with these patients because you want to avoid a vasovagal episode. You want to try to avoid that increased intrathoracic pressure that can cause damage to their sternotomy. So your strengths assessment will focus more on active range of motion and functional strength only. And then you also want to avoid treatment within 30 minutes of a large meal, just to ensure that the heart has optimal oxygen perfusion and blood flow, and that's not going to the GI system instead. Another precaution I wanted to talk about is ejection fraction. So ejection fraction is how much blood the left ventricle pumps out with each contraction. And you can see with the formula to the right, it's specifically the stroke volume, which is that blood that's ejected from the ventricle over in diastolic volume, which is the volume of blood that was in the ventricle before the contraction, times 100 to give us a percentage. And then normal is 35 to 50%. However, if you have a patient that has an ejection fraction at less than 35%, this can increase the risk of heart failure. So you need to be really cautious of any potential symptoms. And the signs that you really want to look out for are chest pain, lightheadedness, nausea, vomiting, jaw, neck, and back pain, left arm and shoulder pain, and shortness of breath. Okay, there is an extensive list of contraindications to cardiac rehab. I put those all in the addendum, and I wanted to highlight these 3 in this presentation. So if there is persistent hypotension, less than 90, if there's abnormally high systolic, greater than 210, or diastolic greater than 110, if the patient has unstable angina or a change in symptoms, this is a contraindication to cardiac rehab. Okay, now I want to go over the new sternal precautions called Move in the Tube. And I want to give a shout out to Pierre Clay, who's an occupational therapist at Cottage Hospital, because he really spearheaded the initiative to start using these sternal precautions in the hospital. He did a bunch of research and reached out to our cardiologists and cardiothoracic surgeons to clear us to use these sternal precautions in our treatments. And I really feel like it's revolutionized the way that we're able to work with our patients in the hospital. So I'm extremely grateful for all of his hard work. This was a study done in 2016 at Baylor University, and it's an alternative approach to sternal precautions after a sternotomy, and they specifically call it Keep Your Move in the Tube. And the authors specified that the reason that we have sternal precautions is obviously to avoid sternal wound complications, specifically sternal wound dehiscence, which is at a 0.5 to 8.4% of cases. And that's nationally, that's not in the hospital. But the reason we want to avoid these is because it can increase morbidity, it can reduce the quality of life, prolong or repeat hospitalization, which ultimately is going to increase healthcare costs, and also increases mortality rates to 15 to 40%. However, the authors argue that although these are major risks that we want to avoid, the risk of decreased mobility and bed rest are as great, if not potentially greater, than some of these risks listed below. So they wanted to see if we could create a little bit more wiggle room in our sternal precautions. And so they did a study with patients post-CABG, 3 to 7 weeks post-CABG, and they assessed how much force was put on the sternum during everyday activities, such as mowing the lawn or pulling a dishwasher rack out, lifting a gallon of milk or pushing a door. And what they found is a lot of these daily activities are actually putting more force on the sternum than our traditional sternal precautions of not lifting anything, pushing, pulling, or lifting anything greater than 10 pounds. So then they came up with Move in the Tube. And for this, they wanted to limit the movement of the humerus in order to decrease the pull on the sternum. And anatomically, this makes sense because if we're keeping our arms adducted by our sides, then we're not going to be pulling on that pec major, which would be ultimately pulling on the sternum and the incision. So what they suggested doing is teaching your patients that they're basically in a tube around their body, and you always want to keep your arms inside that tube. So there's no pushing, pulling, or lifting greater than 40 pounds in the tube, and no pushing, pulling, or lifting greater than 10 pounds outside the tube. And this has really opened up a lot more for us in the sense of functional mobility. Specifically, I want to go over bed mobility, as you can see in the left-hand side of this picture. Traditionally, the way that we would teach bed mobility with sternal precautions is for the patient to hold on to a heart pillow, log roll onto their side, and then try to use their abdominal muscles to come up to a seated position, normally with assist from the therapist. However, with these new sternal precautions, the Move in the Tube, you have the patient go onto a log roll, and then they can use their forearm to press up and do an elbow extension, basically like a tricep press to sit up. which is much easier for the patient, and it's still maintaining those sternal precautions by keeping their humerus in by their side. This opens up a lot more possibilities for all sorts of functional mobility as well, such as wheelchair mobility, opening a door, and functional transfers as well, because now we can have the patients, instead of trying to transfer while holding a heart pillow, they can bring their arms down onto the armchair rests, keeping their elbows in by their sides, and then press up, again, using their triceps to stand, which has made our functional transfers a lot easier as well. So again, this has really revolutionized everything that we're doing in terms of sternal precautions and functional mobility, and it's made it a lot easier for the patient to recover. Okay. And now I want to go over some cardiac rehab outcome measures. I reached out to Heather Stevens, who's the cottage librarian, and asked her if she could do a lit search looking at cardiac rehab outcome measures. And she came back with a whole bunch of articles that was great, because then I got to read through a ton of articles. But I picked two that I feel like are going to be the most relevant for this in-service. So we'll go over those ones together. So this is a meta-analysis and systematic review that is titled Exercise Parameters and Outcome Measures Used in Cardiac Rehabilitation Programs Following Median Sternotomy in the Elderly. And this systematic review took an international approach. They looked at the USA, Germany, Austria, Italy, and Japan. And then the articles that they used, the inclusion criteria was cardiac patients at least 65 years old who had undergone valve surgery or coronary artery bypass graft with a sternotomy, and who were also enrolled in a cardiac rehab exercise program. So this meta-analysis looked at 5 electronic databases for articles that were published after 1997, and they narrowed it down to 11 articles that were included in the study. So the outcome measures that they looked at were the 6-minute walk test, the timed up and go, cardiopulmonary exercise testing or graded exercise test, the hand grip dynamometer, and isometric knee extension. And what they found was the 6-minute walk test was statistically the most significant for positive effect on functional recovery. I do want to note that all of these were all the outcome measures were statistically significant, but the 6-minute walk test was the most significant, statistically significant of them all. So speaking of 6-minute walk test, I also looked at another study. It was a randomized controlled trial that looked at the effects of different rehabilitation protocols in inpatient cardiac rehabilitation after CABG surgery. So for this RCT, they looked at 40 patients that had undergone a CABG, and they divided them randomly into 4 groups. The first group, the therapeutic intervention was inspiratory muscle training, upper extremity and lower extremity exercises, and early ambulation. Group 2 is the same as group 1, but without the inspiratory muscle training. Group 3 was only inspiratory muscle training, and then group 4 was a control. And then they looked at the 6-minute walk test before surgery, after surgery, and then after hospital discharge. And what they found was that all 4 groups showed statistical significant improvement in functional capacity from baseline. And that's indicated by the less than 0.05 p-value at the bottom of this graph. So again, just another indication that 6-minute walk test shows statistical significance for us to be using in assessing pre and post intervention for our patients' status post cardiac or status post CABG surgery. And then also with these patients, it's very important to be taking vitals before, during, and after exertion, specifically looking at blood pressure, heart rate, O2 sat, and symptoms, just to make sure that they're hemodynamically stable, and also to see how that progresses as you work with the patient. In order to get a more subjective measure of their exertion level, we can use the Borg rate of perceived exertion. And the numbers in this scale correspond with the heart rate. So this is a way for you to kind of judge if what your patient is subjectively telling you is fairly accurate. If they're saying that they're working very, very hard and then their heart rate is only at 90, then this may not be the best outcome measure to use. Another thing to take into account is if the patient is on beta blockers, then that's going to affect their heart rate, and you won't be able to correlate their subjective response with the perceived exertion rating either. Okay, lastly, I want to go over the home walking program and post-op sternotomy therapeutic exercises that we provide our cardiac rehab patients here in the hospital. So this is the walking program that we ultimately want our patients to progress to before they go home. And in stage 1, they're going to be walking 5 minutes, 4 times a day, broken up throughout the day for a total of 20 minutes. After they're able to do that 3 days in a row and they feel comfortable with no adverse symptoms, then they'll move on to stage 2. And at stage 2, they're going to increase the time to 10, but decrease the frequency to 2 times per day, still at 20 minutes total. Same thing, once they can do that for 3 days in a row, then they'll move on to the next stage. And this doesn't necessarily mean that they're going to be in each stage for 3 days. They could be in stage 3 for 10 days and stage 4 for 5 days, but it's going to be a minimum of 3 days each day just to make sure that they're progressing slowly and appropriately. And then the adverse symptoms that we like to go over with these patients to be aware of is if they're having any faintness, any lightheadedness, if they have a racing pulse, or they're feeling any shortness of breath. We want them to just stop exercising, let those symptoms subside, and then try exercising a little bit later. If they have those symptoms again, then they should probably be contacting their doctor and making sure that they're appropriate to be exercising. We also like to educate the patients on best times to be exercising. It's getting extremely hot here this summer, so making sure that they're not walking in the middle of the day, trying to go really early or really late when it's cooler, making sure that they're hydrated, not exercising within that 30-minute window of eating a large meal, and then also making sure that they're walking either with someone or at least having a cell phone with them in case they needed to seek any sort of assistance or medical help. And then these are the post-op sternotomy therapeutic exercises that we provide to the patients and that we go over with them just to make sure that as their sternotomy is healing, that they're not in a contracted state when they leave the hospital. So working on cervical spine range of motion and shoulder girdle range of motion as well by doing shoulder shrugs, shoulder flexion, side bending, shoulder extension, as well as neck flexion, chin tucks, neck side bends, and active neck rotation. So the take-home message for this presentation is to make sure that you're monitoring precautions and contraindications to treatment closely when working with these patients. The new sternal precautions are move in the tube, so no pushing, pulling, or lifting more than 40 pounds when you're in the tube, keeping those arms adducted by your sides. No pushing, pulling, or lifting more than 10 pounds outside the tube, reaching forward or out. And then the 6-minute walk test is going to be the most statistically validated measure for assessing functional capacity improvement in these patients. Here are some of my resources. Does anybody have any questions? And I can make those handouts available to you as well, the walking program and the sternotomy therapeutic exercises, if that's a resource that you would